auditory pathway. In the auditory pathway, first the nerve fibers from the spiral ganglion of Corti. From here the spiral ganglion of Corti, they reach into the dorsal and ventral cochlear nuclei, which is present in the upper part of medulla. After reaching into the dorsal and ventral cochlear nuclei, you can see the cochlear nuclei. So after reaching into the cochlear nuclei, they reach into the second order neurons, pass mainly into the opposite side. So these are the up to here, you can see these are the up to here first order neurons, that is reaching up to cochlear nuclei, and the second order nuclei reach into opposite side to the superior olivary nucleus. You can see the superior olivary, these are the second order neurons, and they are moving into the opposite side. You can see these are moving into the opposite side, and some are moving on the same side. So these are the same side and these are the opposite side. And next, after from the superior olivary nucleus, the auditory pathway passes upward into the lateral laminescus. So you can see these are moving into the lateral laminescus. So here the crossing as takes place. So first they are moving here. The second order neuron is moving in the same side of a superior olivary nucleus, but here the crossing over takes place and they reach into the nucleus of lateral laminescus, but this one follows the same pathway and reaches the nucleus of lateral laminescus. And from this lateral laminescus, they may bypass into the nucleus of inferior colliculus. You can see they are reaching into the inferior colliculus, and from the inferior colliculus, these fibers they reach into the medial geniculate nucleus. And from the medial geniculate nucleus, they finally reach into the by the auditory radiation into the auditory cortex, which is also known as the primary auditory cortex. So this is where located mainly in the superior gyrus of the temporal lobe. So this is the auditory pathway. So here what are some other important features are the signals from the both ears. Actually this is from the one ear, so even from the signal of the both ear from other ear also enters here. So these signals are transmitted by the pathways of both sides of the brain with a preponderance of transmission in a contralateral pathway. So there are at least 3 places in which the crossing over takes place. So the first place where the crossing over takes place is near the trapezoid body, and the second place is between the 2 nuclei of the lateral laminescus. And next, this you can see, so first crossover is near to the trapezoid body, and the next crossover is between the 2 nucleus of the lateral laminescus, and the third crossover is between that is a commissure connecting the 2 inferior colliculi. So here you can see this is a commissure connecting the 2 inferior colliculi. So here the third crossing over takes place. So these 3 crossovers we need to remember. And next they also give many collateral fibers, the first collateral fiber is giving to the reticular system for the activation of whole nervous system in the case of any listening to the loud sounds, so that all body gets aware. And next other collaterals are also given to the vermis of the cerebellum, cerebellum part. So why we are giving cerebellum, because any kind of sudden noise, when there is any kind of sudden noise, we can change our equilibrium of position. So this is giving to the collateral of vermis of cerebellum. And next, the third point is the spatial orientation. They have 3 spatial orientation patterns. So 2 patterns are present in the inferior colliculus, and the 1 precise pattern is present in the auditory cortex. So these are the 3 spatial patterns. These are the important points we need to remember in the auditory pathway. And next, coming to the functions of the cerebral cortex in hearing. So the cortex also extends on the lateral side of the temporal lobe. So this cortex also extends on the temporal lobe, that is up to the insular cortex, that is the lateral portion of the parietal operculum. So up to lateral portion of parietal operculum this extends, that is the cortex extends. And there are 2 separate subdivisions, like the primary auditory cortex and the auditory association cortex, also known as secondary auditory cortex. So what is this? Let us see in the diagram and understand. So this is the primary auditory cortex and this is the association cortex, also known as secondary auditory cortex. Medial geniculate body activates the primary cortex, and this association cortex is activated by the primary cortex. Secondary may also be activated by the medial geniculate body's thalamus associated areas. And next, the destruction of both primary and secondary. If the primary cortex is damaged, reduces one sensitivity for hearing, and destruction on one side. Actually these are present on the 2 sides, the primary. So if it is destroyed on the both sides, it decreases the sensitivity for hearing, and destruction on one side only slightly reduces hearing, that too in the opposite side, because the crossing over takes place. So on the opposite side it reduces slight reduction in the hearing. And next, coming to the auditory association areas, that is nothing but the secondary cortex. So here they do not decrease a person's ability to hear, but they can differentiate the sounds, even interpret at least a simple pattern. However, if the person is often unable to interpret the meaning of the sound, so what happens if the secondary part is damaged? Actually, because of this primary part is intact, so he can hear the noise or he can hear what we say, but he can't understand the meaning of it. For example, we say him to dance or sing, he can listen to us and also reply what we said, but he can't understand the meaning, so he can't dance or he can't sing what we said. So that is what happening in the case of secondary cortex disability. So this is because of the destruction in the lesions, lesions in the posterior portion of superior temporal gyrus, that is also known as the vernical area. So the lesions in the vernical area destroys the secondary cortex, that is nothing but association cortex. So he also lose the ability to understand the meaning. And next, coming to determination of direction from which sound comes. So the direction of sound is mainly because of the pinna, which says from which side the direction is coming, whether from upside or lower side. So this is mainly because of pinna, and it has the two principles, that is the time lag between the entry of the sound and into the ear, and next one is entry into the opposite ear, and its entry into the opposite ear means the time lag by which the sound is entering into the one ear and opposite side other ear, and next one is the difference between the intensities of the sound in the two ears. So by this mechanism we can understand this. So the first frequencies are below the 3000 cycles. So this is what the first mechanism functions best at the frequency below. The first mechanism is the time lapse, that one 3000 cycles, and best at the higher frequencies, because it is heard in the greater sound barrier, all these frequencies. And next, the time lag mechanism discriminates the direction more exactly the intensity becomes, because it does not depend on the extravenous factors but only on the exact interval of time between the two acoustic signals. So this we can understand easily. So if a person is looking straight forward, for example, to understand this we have example. If someone is looking straight forward, then the source of sound, the sound reaches both ears exactly at the same time, because straight forward only. But if some sound is more towards the right side or left side, that side only the sound comes more than the other side, because that side actually, as the sound is nearer to it, the nerve catches it fastly and stimulates it, so we can hear it sharply better than other side. So this discriminates is achieved mainly by pinna. So that was we discussed, the quality of direction of sound is mainly because of the pinna. And next, the centrifugal signal from the central nervous system to the, so we have seen the ascending pathway. Now we need to see the descending pathway, how it comes. It comes because of the retrograde mechanism, mainly coming from the superior olivary nucleus. So from the superior olivary nucleus there is a hair cells in the organ of Corti, so which leads to the retrograde mechanism. This is actually inhibitory mechanism, which is reducing the sound intensities to 15 to 20 dB. So this is mainly, one can understand this by allowing a person to direct his or her attention to sounds of party. So when this we can understand by, if you participate in any kind of concert in music concerts, there are many singing orchestras, but you can able to listen only the singer voice more clearly. This is because of this mechanism, that is the retrograde mechanism. So example, the single instrument sound can be focused in a symphony of orchestra. And next, coming to the hearing abnormalities, that is deafness. So there are mainly two types of deafness, that is the impairment. If there is impairment of cochlea, auditory nerve and the central nervous system, this is known as nerve deafness. This is very serious. It is permanent deafness. We can't repair or we can't make it proper. And the other kind of deafness is impairment of physical structures, like in the ear, like cochlea or any other structure made or auditory nerve is destroyed. So this is permanent deafness if all those are impaired, but only some structures like tympanic ossicular system are lost, then we can also set it again. We can regenerate it by some other mechanisms or surgical processes. So what is audiometer? Audiometer is used to determine the nature of hearing disability by mainly we use earphones and it is connected to the electronic oscillators. So the tones are ranging from low frequencies to high frequencies. So in this audiometer we can understand whether the deafness is for low frequencies of sound or high frequencies of sound. Actually it is known as zero intensity level sound. At each frequency is the loudness that can be heard by the normal ear. So the loudness must be increased to, for example, if the loudness must be increased to 30 dBs, that is that particular person have a hearing loss of 30 dB at that particular frequency, because he can't hear that 30 degrees, so he is asking us to increase it. So we can find it like this. So by using audiometer we can find the deafness in which frequency it is present. So hearing loss is determined mainly by the audiogram. So by this audiometer we take a graphs like this. This is known as audiogram. So by this audiogram we can determine how much hearing loss he has. And the audiogram in nerve deafness, that is mainly due to damage of cochlea or auditory nerve or central nervous system. So loss the ability to hear by both air conduction and also bone conduction. So air conduction means by the cochlear passage, and bone conduction by passing into bony labyrinth. So in this both cases we are going to test by the audiometer. And the high frequency sound like deafness could be caused by the damage to the base of the cochlea. So sometimes because of high frequency sounds it causes the damage of base of our cochlea and leading to deafness. This is mainly seen example in the olden people. So in the olden people their base of cochlea damages and they can't able to hear properly. And next, coming to other patterns of nerve deafness are like deafness for the low frequency. So in high frequency sometimes they can't also hear the low frequency sounds because of excessive and prolonged exposure. For example, you can take example of rock band and jet airplane engine. They're prolongedly working there, so there are always prolonged exposure to very loud sounds, so their ears slowly damage. So and also there is a deafness because of drug sensitivity, like our ears are sensitive to some types of antibiotics, like you can take streptomycin, gentamicin, kanamycin and also chloramphenicol. And next, coming to the audiograph of middle ear conduction deafness. This is mainly the deafness because of fibrosis in the ear. Fibrosis may be, if it is hereditary, then it is then it's called osteosclerosis. If normal fibrosis also, it may cause the destruction deafness mainly in the middle ear. And next, coming to the ossicles from the tympanic membrane to the oval window. Actually the sound waves, because the main problem in this fibrosis is the sound waves are not able to transmit from the ossicles of the ear from the tympanic membrane to the oval window. So when then oval window it will not reach, and it will not vibrate the basilar membrane, so leading to deafness. So one is the faceplate of stapes. Sometimes whatever the stapes get ankylosed, that is the bone is overgrown. So when it is overgrown, it doesn't allow the sound to transmit from the oval window. Then it may also lead to temporary deafness, but not permanent deafness, because it can be removed by surgical process. So that if the stapes is removed and we had some metal prosthesis or Teflon product instead of real stapes, then it may allow the transmission of sound and again the ear becomes normal. So this is the temporary deafness which can be done by using surgical instruments. And that before fibrosis, it is in the middle ear this is also because of fibrosis in the ear. It's all about hearing physiology.